And take it away, Dr. Galentine.
Okay. Well, great. Well, welcome this afternoon. I'm Dr. Galentine. I'm a pediatric neurologist, epileptologist over at Stanford University and Lucille Packard Children's Hospital. And so today it's my pleasure to talk to you guys about kind of the ABCs of pediatric epilepsy surgery and really kind of walking you through the entire pre-surgical evaluation, really from the time you do your initial evaluation with your neurologist all the way through the operating room, and really trying to give you an overview on kind of what to expect. So this will be there'll be three speakers actually today. First will be myself, who will kind of be describing a lot of the overview of kind of the pre-surgical evaluation, and then Dr. Grant will be discussing the surgical side of things. And then we actually have one of our pediatric epilepsy surgery patients, Johnny Gaina, who actually will be joining us to kind of just share her experience some. And so hopefully this will be a good interaction, and we'll have some time for some questions that you can specifically ask Johnny, as well as us at the end of the talk. Okay, so what is epilepsy surgery? So really this is a neurosurgical procedure that's going to be, its primary aim is to kind of stop or reduce seizures, as well as improve the quality of life of patients with refractory epilepsy. So how do we define refractory epilepsy? Well, this would be the failure of two or more medications that have been appropriately chosen and that have been appropriately dosed. And so really any patient that meets that definition of refractory epilepsy should be referred to a tertiary care epilepsy center, at which point a discussion about all of your therapeutic options should be performed. And within this should be a discussion as to whether you're a potential pre-surgical patient. So why is it important for that conversation to occur? And so, well, you really want to make sure that you've explored all the options that you can for the potential treatment for refractory epilepsy. And we know that in general, there's a number of anti-epileptic drugs that could be out there and be tried. We know that about 50 to 60% of patients respond to their first drug that we try. So the majority of patients actually will respond to their first medication. About another 10 to 15% will respond to their second. But after we failed that second medication, there's only about a 5 to 10% within the group then that will actually become seizure-free after we start exploring the third AED. And those numbers continue to go down as we kind of try various different medications. And so at least about 20 to 30% of patients then with this very difficult to control epilepsy. Um, and so because of that, it's really important then to think about what other potential options there may be. Dietary therapy is certainly an option. And so there are things like the ketogenic diet and the modified Atkins diet and the low glycemic index diet. And so all of these dietary therapies are potential options for certain patients. About half the patients we try on the diets will have about a 50% reduction in seizures. And that's kind of across all three of those potential diets. And about 10 to 15% of them will actually become seizure-free. Epilepsy resective surgery, however, really is of these options, probably one of the only ones that oftentimes will result in potential curative treatment. And so where potential all seizure freezes may be gone and actually even be able to come off all medications. In patients that seizure freedom may not be an option, there is something that we refer to as palliative epilepsy surgery, which would mean that we would do a surgery with the goal in mind of just reducing overall number of seizures, realizing that we may not be able to get all the seizures to go completely away. And in patients who have very, very difficult to control seizures that are frequent and life-threatening, this might be an option that we might think about doing as well, even if we don't believe that we could get them completely seizure-free with the surgery. There are other options like neurostimulation, which would be vagal nerve stimulators, repetitive nerve stimulation or RNS, as well as deep brain stimulation that also are options for folks who aren't actually epilepsy surgery candidates and have explored these other options. So who would we at this point call the ideal surgery candidate? The ideal candidate would actually have focal seizures, so seizures that would particularly start in one particular spot within the brain. And ideally, they would actually have an abnormality on their neuroimaging, on their MRI, that we could then point to and say, okay, this likely needs to come out. And then removing that actually area of the brain would not result in any type of neurologic deficits. So the surgical outcomes are really optimized whenever we can kind of check all of these boxes. And really the initial pre-surgical evaluation is really aimed at trying to identify where those seizures are coming from, and or is there an accompanying structural lesion. And there are a number of tests that we're going to talk about here in a moment that kind of helps us fine tune those things and try to answer those questions. Importantly, though, not being an ideal candidate does not necessarily mean that you're not a surgical candidate. And in fact, there are many patients that have epilepsy surgery that don't have abnormalities on their MRI. So this is where the other testing becomes important. So what does the pre-surgical evaluation include? Well, initially, it starts with a consultation with an expert in epilepsy, either adult or pediatric, depending on your age. We then do a detailed history, and the aim of this history is really kind of determining what types of seizures you may have, whether they're focal, which again means starting in one particular spot, or generalized. We also get information like the age of the onset at which the seizures occurred, the number of different seizure types that you may have, the description of them. The description is important that it oftentimes allows us to kind of help localize where the seizures may be coming from within the brain based upon the behavior. We ask about the duration and the frequency and the potential triggers. Uh, Importantly, we ask about how these seizures are actually impacting your quality of life and how is it actually impacting your ability to function within the day-to-day. And is it actually allowing or not allowing you to do things that you ultimately want to do? We will ask about prior anti-seizure drugs, what side effects you may be having, because oftentimes that weighs into some of the decisions. We ask about your past medical history and birth history, your family history, and then as well as your developmental history. And are there skills that are present that are actually regressing? And then lastly, we ask about social history. And this is oftentimes very important in terms of, again, how's this impacting your ability to function within your life? Is it impacting your occupational goals or your living circumstances or your school performance? We also will do a physical exam, which then allows us to also may help us hone in on one particular area based upon any abnormalities we might see within that. We also assess your vision and your motor function and your cognition and your language. All of these things kind of weigh into decisions, especially whenever we look at where seizures may be coming from and what could be potential side effects of the surgery if those areas happen to be involved where the seizures are coming from. Um, we also will do an MRI of the brain, or at least we'll look at your old MRI of the brain and assess whether that study was adequate or not. Oftentimes, initial MRIs may not be performed on scanners that provide as quality of imaging as some of the newer scanners that we may have, or it may not actually provide the thickness or cuts of the brain that we're looking for, so we can get greater, finer detail. So depending on the adequacy of the study, that might be something that needs to be repeated. We then will also review prior EEG data. And then most importantly, we'll oftentimes will bring you into the hospital where we actually will perform a video EEG and try and capture seizures that will kind of help us localize where the seizures are coming from. So whenever we talk about the MRI of the brain, we oftentimes will talk about it's important for you to have a lesion, an abnormality that we can point at, and that oftentimes improves your surgical outcomes if you have that. But as you can see here, all these images are quite different, and all the abnormalities are quite different, and and they're not all necessarily weighted evenly, none of these images either weigh or rule you out of potentially having a surgery. And in fact, it may be something as simple as actually having a little scar within your temporal lobe, which is kind of seen here, versus a little subtle brain abnormality, which in terms of how the brain formed, which is located here, versus a larger brain abnormality where this entire section of the brain is actually abnormal and did not form appropriately when the brain was forming. It could be something like a stroke, or it could be something like a condition called tuberous sclerosis, where you have little small tubers within the brain that all of which can potentially cause seizures. Um, or it actually might just be normal, where you actually don't have any abnormalities at all. And all these people are still potential surgical candidates, depending on what we see with the rest of the workup. So the inpatient video EEG monitoring, so this is scalp monitoring. So this is where we actually put the electrodes on the outside surface of the brain. And the goal of this potential workup is for seizure characterization, for us to kind of localize where the seizures are coming from. And so Depending upon your frequency of your seizures, this admission will typically last anywhere from 1 to 7 days. The medications are often weaned during this admission to try to activate seizures and try to get them to come out. We typically would like to see at least 3 seizures during this day so that we can make sure that we feel comfortable that they're all coming from one particular spot. The video that's obtained oftentimes will allow us to capture details about the seizures would have localizing value. So they may allow us to say, oh, these start in your motor area or these start in your language area based upon the behaviors that we may be seeing. Um, if the behavior, or if we are able to identify that seizures are coming from one specific spot, we then may pursue further workup, whether that might be further neuroimaging, or we may just recommend surgery at that time. So it really just depends on where we feel like the seizures are coming from, and what more information we feel would be helpful in making your procedure most successful. If the patient is found to actually have generalized seizures, or if the seizures are starting in one or more spot, like multifocal seizures, then we actually might recommend further medical management, dietary therapy, or one of the neurostimulators that I had previously mentioned. Um, so, so sometimes the EEG recordings that we gather, though, are not definitive, and they may not really give us all the localizing information that we wish, or the MRI actually may not show an abnormality. So in those circumstances, there are some other tests that we might want to consider doing. And those would include a PET scan, a ictal SPECT, a magnetoencephalogram. And I'll get into each of these here in a moment. There's also some functional tests that kind of give us some information about how the brain is working in different areas. So things like neuropsychiatric testing, where we actually will look and test memory and cognitive abilities. Functional MRI can be very useful in identifying motor and language areas. A test called a WADA test, which oftentimes will allow us to assess memory and motor function, as well as visual field testing, which will allow us to kind of see how your vision is working if your seizure focus happens to be in an area where vision is located. So a PET scan actually, this test basically shows how the brain uses sugar. And so a very low safe dose of radioactive tracer is injected in the arm, and then a scan is performed. And it shows how that sugar is flowing through the brain. And so, and not all PETs look the same depending on where you have them done, but typically higher areas of color or brighter colors are higher use of glucose. And then oftentimes lower areas, like you see down here in this temporal lobe, is an area where it's not using sugar well. And oftentimes a seizure area of seizure focus, because the brain is not working well in that area, will show up dark on a PET scan. And so, and then if it happened to be that we captured a seizure during a PET scan, sometimes it may end up bright, something that looks like this. And so, but only in one area. And so most often seizures are actually done during periods where in between seizures. So we're looking for more of these dark spots. A PET MRI is a newer type of test that's available, and this kind of combines your MRI and your PET scan, and it more kind of accurately gives us information whenever you actually transpose the PET onto the MRI, and it actually gives us more abnormal findings than what we would traditionally use with the traditional PET CT, which about 50% of the time we can actually find more abnormalities than what we did with the CT. Also, the PET MRI has improved safety because of reduced radiation exposure, and so it's about 50% less than what you would get through a PET CT. And then there's also just the convenience of being able to do your PET and MRI at the same time in the same appointments. A magnetoencephalogram, or a MAG, this is a test that actually looks at small electrical currents, which then produce magnetic fields arising from the nerve cells of the brain. And so these abnormal fields are then able to be mapped onto the MRI, which is what you kind of see here in these little triangles. that then kind of help provide us with areas, one, kind of helping with anatomic information, but also in terms of looking for little subtle abnormalities within the brain that may actually be causing seizures. And we correspond these spikes with what's going on in the scalp EEG, and it kind of helps lead us to some of these areas of greater suspicion. So it kind of gives us a greater detail of where these potential seizures may be coming from, and it serves as a nice additional test to the MRI and the PET and the other monitoring that we've already talked about. And it often has to be quite reliable where these epileptic discharges are coming from. The SPECT scan is a study that actually looks how the blood flow is going through the brain. And usually this is a study where again, a safe, short-lived radioactive substance is injected into the arm, and it's usually during a seizure. And then following that, we are rapidly taken down to a CT scan. And then what we see during a seizure is because the brain is firing electrically very quickly, repetitively over and over again in one particular spot, you often will have increased blood flow, which actually turns up in a bright red spot with an ictal speck, so during seizure. As opposed to a scan that would be performed not during the seizure, you don't see that red spot present. So oftentimes the blood flow in that area is actually somewhat decreased. After these two tests are then performed, what can be done is it's called a subtraction, where we take the two images and transpose them on each other. And then actually, we can do some further processing that maps it onto the MRI. And then you can actually see a very nice delineated hotspot where it looks like the seizure is potentially coming from. And so another additional test that can kind of help point us in the right direction where some of the other tests may not be as clear. Neuropsych testing can also be very helpful. This is formal assessment of cognitive abilities where they actually look at the intellectual ability, look at processing speed, memory, concentration, look at problem solving skills, mood, and personality. And this too may have localizing value in regards to the potential area where the seizures may be coming from. For instance, if a seizures are coming from the one temporal lobe, the verbal memory may not be quite as good as it should be for standard. And so if folks are having somewhat other problems with some of their executive functioning and processing speeds, that sometimes can be more indicative of a frontal lobe issue. And so that kind of helps us cement some of these areas of dysfunction. It also helps us in identifying what potentially may be at risk if we were to take something out. So that sometimes can be helpful as well. And it really also allows us to kind of track progress over time, because many patients who are having very difficult to control seizures are oftentimes having some cognitive impairment in association with that, and it allows us to check the potential improvement in that following the surgery. So functional MRI, this is a test that actually looks at blood flow and how the blood is flowing through the brain. And basically, it's an MRI that's done while a patient's awake and following commands. And they may be asked to move an arm or a leg. And whenever they do that, you'll get this bright signal in the area of the motor area. And the same thing can be done for language. And this is very important and helpful whenever we're talking about trying to identify areas that would be at risk if we were going to do surgery in particular areas. And as we said before, we would try not to cause any potential deficits with our surgery. So a WADA test is a test that's not done very often these days, but it's a test that actually we use whenever we're trying to sort out memory function and as well as motor function. And so there are some patients where their motor function may have moved to one side of the brain following an injury, or their memory may have moved and to the opposite side. And so this test allows us to put the brain asleep on one side. It's an invasive procedure where the interventional radiologist actually performs what's called a cerebral angiogram, where they actually slide a little catheter up in this blood vessel and squirt dye so they can see the blood vessels. And then they actually inject the medication, which basically puts the brain asleep for about 5 minutes on one side. And during that time, we can assess whether the patient can move and whether they can talk and test their memory during that. That allows us to pick one side versus the other as to what areas have those functions are on. And lastly, visual field testing. So this is helpful in one, trying to determine whether a patient already has a pre-existing visual field problem. So some folks that have had an injury to the back portions of their brain back here may already have a visual deficit that they may not necessarily realize. And so we can map those out with an ophthalmologist, and they can kind of help us delineate that. We also can do special neuroimaging, what's called diffuser tensor imaging, where we actually can map the tracks coming back from the nerves in the eye, nerves from the eyes back to the brain, that then allows us to kind of map where those tracks are at, and then potentially try to avoid those as we're doing some potential surgeries. So in general, every patient with refractory epilepsy really should have at a minimum a video EEG and a high resolution MRI with an epilepsy protocol. Following this, further studies may then be ordered based upon what the results of those initial studies show for further potential planning. But not all patients require further testing. It really just depends on what's been found previously on the other tests. So the types of studies that are needed are very individualized. Once all this information is then gathered, we then go to epilepsy conference. And at that time, it's a multidisciplinary conversation between all of the epileptologists, the psychologists, the neurosurgeons, as well as a radiologist, to kind of sit down and look at all this information and determine whether this patient is a good surgical candidate or not, and what's the best way to potentially approach them from a surgical plan. So there are a number of different types of surgical procedures that can be done. And Dr. Grant's going to get into these, so I'm not going to spend a lot of time talking at them, but these are the types of things that we kind of discuss in terms of, should this be a patient that should actually have stereo EEG where we do further monitoring from inside the brain? Should we actually monitor from the surface of the brain only with what's called subdural strips and grids? And then also, once that conversation or that information has been gathered, what type of surgery should we actually perform? And Dr. Grant will talk about those. So after all that has been done, then we then go back to the family and just talk about what we saw in epilepsy conference. What's the likelihood the surgery would make them seizure free? Would they benefit from them? We ask the question whether we really feel like the procedure can improve the quality of life. What are the risks and the potential post-op deficits? And then it's really just important up front to identify what the primary goals of the surgery would be, as well as any potential deficits, and then make sure that they have a really good understanding of the potential for their outcomes and really set realistic expectations up front. So in closing, every patient with refractory epilepsy should be seen by an epileptologist to discuss really all the options that we have available, including possible surgery. And then, candidacy for surgery, though, is very personalized and really depending on the type of seizures that you have, the severity, and the results of all the other ancillary testing, as well as, do we feel like that we will get the desired surgical outcome, and does it outweigh the potential risk of the procedure? So that ends my discussion there. I'm going to transition now over to stop my screen share and flip over to Dr. Grant.
Thanks, Dr. Galantine. Can you hear me okay?
Yes.
We can get everything going here. Is it okay to share my screen now?
Yep.
All right. Looks like the host disabled the screen sharing for the attendee. I don't know if you can enable that, please.
Let's see.
Not sure who the host is. Is someone on from the event?
Yes, sir. We just made you the host, Dr. Grant.
Okay, thank you. Bill, is that okay?
Yep, that's good.
All right. Good to see you, or here at least be talking to you all. I'm sorry we're not there in person. We can all hang out together, and that's always the fun part of this meeting. We get a chance to talk with you after these talks and get a chance to hear about your story. But I'm going to go through a little bit of the surgery. I know you've had a bit of this today as well. I'm going to dovetail off what Dr. Galantine was talking about, but not really go through a lot of the workup of what we're doing. And it's important to remember that, there are several, people in the US alone, that have seizures that are good candidates, for surgery, that we just haven't been able to get them in, or sometimes the neurologists are still doing medications and they may be on seventh or eighth medication. And we would push medicine, of course, as much as we could, for a period of time and before we'd even think about surgery. We don't want to be operating on people who are well controlled for seizures. That would be a rare thing. But it's important at some point then to move forward and just make sure that you're not a surgical candidate, particularly if, like Dr. Galantine said, it's coming from one side of the brain or one area of the brain. It gives us clues that we could push further. It doesn't mean it's a guarantee, but at least we would keep pushing to see if there's something we could do. And then, a certain percentage of these patients, will then end up getting surgery and do so much better than if they were on medication alone. And it's been studied over the years, and children are more likely to undergo surgery than adults. A lot of the adults just say, "Well, I'm going to live with this. I've been doing with this so long." As a child, it's a different story because we're being a lot more aggressive than we used to be because we're worried about the development. And we worry that if we catch it too late, that no matter what we do, they just won't do as well. We're very worried about the quality of life, the long-term outlook, and the goal is, remember, to be independent in life and not having any seizures. And that might be still on medicine. It's a chance to come off medicine, but the goal is first to stop the seizures. And there are many barriers, right? Many people feel just like this is the last ditch thing, and it should not be thought of as the end of the road. It's an opportunity that exists for every patient potentially that you want to think about. It's not experimental. It's something we hear is that we're somehow experimenting. It's something that, has rigorously been tested, that this has improved results in terms of compared to medicine alone. The risks, are they too high? And this is where we keep improving, I think, on what we've done before. We've gotten a lot more minimally invasive. We do so much more with the stereo EEG approach that Dr. Galantine hinted at. That takes some of those risks away that we used to have to do such a large surgery up front, that we don't do that anymore. And patients, just for a good reason, don't want their brain removed. And I can understand that. And what we're taking out is not normal brain. That's the important thing. These are areas of the brain that are very sick, and these are areas that the brain actually functions better without these areas that are disrupting the whole epilepsy network in the brain. But it's complicated, right? You may have this epileptogenic zone, which is where the seizures are starting. This is maybe where the symptoms start. If we go too far, we might get into the areas where we're going to hurt language or areas of motor function, for example. There's the areas where the seizures start and spread. All these have to be taken into account. And that's why it's getting more and more complicated the more we look. And we have to be careful not to have blind spots and really keep an open mind when we're thinking about each patient. Every patient is an individual, right? Everyone we have to, almost like a puzzle, right? And really think about as a team, what's the best possible next step, to lead to seizure freedom. And that team is so important. We say at Stanford have a team that's almost 20 some people now every week where we think about these cases together. It's not one person advocating for something. It's a team of folks that are really engaged, trying to think about what can we do next. And this has been studied for temporal lobe, more in adults, that we might take out these areas of the brain. Now we often laser these. But this has been shown, in a randomized study that comparing surgery and medicine, the surgery group does better in terms of without seizures. It's dramatic. It's almost 60% compared to almost 10% in terms of seizure freedom. So big difference. And this does really matter in terms of quality of life. And we know we have to get seizure free to get to that quality of life, to give it a boost. And that's always our goal, if at all possible. Now, I don't want to gross you out, and some of you may be eating or just ate, but this is just to show you an example of tuberous sclerosis. Dr. Galantine showed you some MRI scans. This is an actual tuber in the brain. I don't know if, Bill, you can see my cursor, but this is, you can see.
Yes, we can see it.
Okay, the tuber, this is the surrounding brain around it. Now you might think, oh, just take the tuber out. But again, it's not that simple. The tuber irritates certain areas of the brain around it. And you might find an area, like in this patient, this was the area where the seizures were coming from, which were borderline to the tuber, which had to come out anyway. But if we didn't take this out with the tuber, the child would not have been seizure free. So we have to do our homework. Although it seems easy just to remove this, it may not be needed because this is the culprit. So we often have to do something even more. This is another example in the MRI scans where you can see cortical dysplasia, areas of the brain that were not made in a way that has good architecture. You can see that in the MRI scan. We study this tissue now in a collaborative we're part of nationally, where we look at this tissue, and there's actually aberrant genetics. There are mutations in this area of the brain that are different from the rest of the brain. So that it's becoming more difficult to understand some of these networks. Where is the border? Where do we stop in terms of what we do? That's always a question. This is another one where here's the tuber. You can't see it because it's something you can feel, but this is the motor area here. And there are areas around this that we also had to take, again, to get this child seizure free. We have to do that homework up front. We can't just assume that, oh, take this area out in the MRI scan like we just saw, take this out, everything will be fine. You can't even see this, at surgery. Where are the edges? It doesn't look any different, right, than the brain around it. I'll try not to gore you too much more, I promise. So thinking about lasers and, Star Wars, Star Trek, these days are in the past, but, luckily for epilepsy, it's ready for prime time. And we really are thinking about now of how we can laser some of these areas. There's two different machines that we use, Visualace and Monteris. They both are a little bit different, but the same idea, and that we're targeting areas of the brain that we map and already determine up front what we need to do, and then we target them with these lasers called laser ablation. And this is a great advance, particularly for a deep lesion like this, where we don't want to do an open surgery to get down to that deep spot. If we can go in a very minimally invasive way and target it right to the depths. This is an example if we do a 3D rendition of this recent patient. This was a very young girl that had these two areas that we had already done stereo EEG to think about this in terms of the network. We place these lasers in real time. We're watching the laser heat the brain. The purple is the area of the heating that we can see in these different trajectories that we use to treat these seizures in this patient. And it can only be done by putting multiple electrodes around the brain to determine that, well, these are the hot spots. We don't need to take this area. We don't need to take this area, for example. And you can see inside kind of what we're doing in terms of that 3D representation, of these areas that we ablate. Now, you might say, no way, I'm not going to ever go through this. And, we can understand that. It sure isn't for everybody. It's something that we couldn't even think about doing unless we truly felt it's going to help you. There's always vagal nerve stimulators. There are other things we think about if we don't want to do something in the brain. And I'm not going to dwell on that. But I also don't want you to think about this, that you're going to have all these pins in your head. When you think about stereo EEG, it has really transformed what we do to work these patients up. This is the old days and the way I trained. Open techniques, large craniotomies, placing grids on the surface of the brain, keeping these electrodes in for maybe a week or 10 days. And we're pretty time limited with these grids. A lot higher risk in terms of the patient and a lot bigger surgery up front to figure out what to do. I think the worst thing I remember is, doing this large grid and then finding out that I don't think we can do anything to help. That's just a terrible thing. We went through this large operation and we didn't really help the patient. Versus this, where we place these small electrodes now, much more minimally invasive, less than a millimeter each electrode, and gives us a much better idea, what we're doing in 3 dimensions. And we can place these, we can navigate in 3 dimensions with our MRI scans. We can do the same kind of analysis of this patient that had quite a bit of onset in the left temporal lobe. You can see how we use these electrodes with these little bolts, and the electrode goes through them to map into these areas of the brain. These are areas of the tuber, another patient with tuberous sclerosis. You can see how we're targeting these different areas of how we reach inside the brain in 3 dimensions, how this electrode might relate to this electrode and that contact, and trying to figure out what we're going to do, for this patient. Sorry. Just got to get past that video. So now we can reconstruct this. You can see how complicated this might get. We have certain electrodes going in the brain. We're mapping motor. Dr. Galantine talked about the MEG spikes, which are these yellow spikes, the dipoles with the red, where the electrodes were, what part of the electrodes were hot. These are the motor tracks in purple, which is called DTI. So we use the entire spectrum in 3D to think about, well, what next? Are we going to laser a small part? Do we need to do an open surgery with a grid? Do we have to stimulate this in the bedside to figure out how this might relate to motor, for example? All this is done now, in 3 dimensions. It's gotten so much more complicated to think about all these electrodes in place. There may be, 15 here, and they're just going up, to be honest with you. The number of electrodes we put in are continuing to go up, just like the grids, the number of contacts we used to put in continue to go up because it gets so much more complicated the more places you might look. And then we might do open techniques or at the bedside where we stimulate parts of the brain. And, we have to make sure if we're going to improve seizures, we are not hurting the quality of life at all. That's one of the biggest concerns we have is we're not improving the seizures and we're some way worse, that we took something away. We never want to do that. We have to map language sometimes, and this patient was very complicated, bilingual. He's speaking 2 different languages, mapping hearing of language, vision of language. Sometimes there's overlapping sites. In English, for example, compared to the functional MRI. This patient was also in Hebrew and mapping those areas which are different than English, and you got to keep in mind. And naming and responding and reading in English, look at how complicated the map gets in a patient with speech and language. Luckily, motor is much more predictive in terms of what we need to do. So in the end, we always want to think about what's more effective than the other. We're always thinking of the subtype. What's the pathology here? How accurately do we localize that focus? And we have other options now, which is really exciting. We don't just take out areas of the brain. We don't just laser them. We sometimes have deep areas we don't want to take out because it might permanently cause harm, like a speech problem. If you had an area in speech, we used to walk away, say nothing we could do. We now can use something called an RNS system, responsive neurostimulation, which is a loop feedback, which it's a smart device where it senses these spikes and then will discharge to try to stop the seizure before it spreads. Now we do deep brain stimulation. We place targets deep into the brain where we haven't actually localized the seizure onset. So I think this is a very exciting approach. Comparing it to vagal nerve stimulator, we hope it's better, but we don't know yet. We need to look at this, and many patients have both. Focused ultrasound is on our horizon. There's a trial that just opened at Stanford on the adult side that is looking at focused ultrasound to target areas deep in the brain without putting anything in, no laser, electrode, nothing like that, completely non-invasive to target areas of the brain. This is our future, right? We don't want to have to stick things in the brain if we don't need to. There's always risk in what we do. So track this focused ultrasound very, very carefully. There are many more centers being developed. I think it's a very exciting innovation for the future. But our limitation is cognitive outcome. We got to make sure the functional outcome of these patients is really what's on our mind the most. We just don't want to take anything away from them. They're already so challenged as it is, as you know, and we really want to try to contribute to improving their quality of life. And just an example of how difficult it is, you can see how one seizure might start and see how it spreads to some of the yellow. This is an article a few years ago, and you can see how rapid the seizures spread. Now, where do we target? Do we target the entire network? Can we target just where the seizure starts? Do we have to cover the yellow areas as well? This is where it's a judgment call, and you don't want one person making that judgment. You really want that team involved to interpret that EEG and do the right thing. So in the future, we're always thinking about how to make things safer from a surgery side. And I hope that you get that message today that's on our mind to be more minimally invasive, more precise, more safe in what we do. We rely on incredible, exquisite imaging now to map out these areas of the brain and the highways, the blood vessels of the brain. We incorporate very sophisticated navigation techniques. We use robotics in the brain, and the robotics have helped stereo EEG develop to make it much more efficient to me to place, say, 30 electrodes in 2.5 hours, something like that. It's about 5 minutes per electrode now to put these in. And then what we might do, we might resect, we might use a laser, we might do the responsive nerve stimulation, deep brain stimulation, and we always have a vagal nerve stimulator or other medical options, of course, that other talks will touch on. So I think I'll stop there. And Bill, if you want to go on to more fun part here.
Okay. Well, thanks, Jerry. That was great. And so if we could have Johnny, her camera turned on. Oh, there she is. And you want to turn your mic on for us too, Johnny?
Yes, sure. Hello.
Great.
Hi, good to see you.
All right, so this is, like I said, like Jerry was saying, this is the fun part of the talk because you guys get to hear from Johnny, so the person who's actually kind of gone through this. And so, so Johnny, we'll just kind of start with asking you a few questions as kind of opener, and then hopefully we'll have some time for some folks to ask you some questions as well. And so, why don't you start with just by telling us a little bit about your epilepsy? So, like, what age did it start, and what is it like whenever you have seizures?
Okay, so I'm 15 right now. I have been having seizures since I was 11 years old, and what it looks like when I have a seizure is my left arm and left leg starts shaking, and I kind of just like lose control over my left side after like it's numb almost.
Okay. And how often have you been having, how often, I know you've had your stereo EEG recently and seizures have calmed down, but before the stereo EEG, how often were you having seizures?
I was having seizures about once a month statistically.
Okay, good. And so, and overall, what do you think that has been the most difficult thing about having epilepsy?
I think the most difficult thing, and probably more people can agree with this, is that I kind of get I'm not able to do most of the things that people at least my age are able to do, such as drive and like swim and stuff like that. And I think that's probably the most difficult thing.
Okay. And then you recently kind of went through, like I said, you actually had an SEEG. Could you tell us a little bit about your initial pre-surgical evaluation? So your admissions and things like what all did you go through and kind of what was that like?
Well, sorry, can you rephrase that really quickly?
Sure. Yeah, I was just wondering could you maybe talk a little bit about your experience with the pre-surgical evaluation, so your hospitalizations and things like that.
Yeah. Okay. Well, I had 2 EEGs. The first one didn't work out that well, but the second one I got a couple seizures in. And then in August I had a stereo EEG, and yeah.
Okay. And so, and whenever you think about the stereo EEG, why don't you tell us about that some? What did you expect going into that? And was it different than what you had expected? What tell us a little bit about the stereo EEG?
It wasn't much different than what I expected. Sorry if you hear some rustling right there. I have guinea pigs. So I expected it to be similar to the regular EEG, which it was. Definitely longer, and then like I would have the leads in my head, but that's what I expected.
Yeah, and Johnny actually, she actually had how long did you have your electrodes in for, Johnny? They were in for quite a while, right?
We were in for 11 days.
11 days. And that's not common necessarily for all of our patients. I mean, quite commonly, some patients may be able to come in from 3 to 5 days, we get the information. But sometimes people's seizures just don't cooperate. And that's where the boat that Johnny kind of felt herself in was that she just wasn't having the seizures and we were getting the information that we needed. So during that, Johnny, was it painful at all to have these electrodes in?
There were just a couple painful things. I had an electrode like right here, which made it hurt when it clenched my jaw, and I also had a couple headaches, I think. Then I think the worst part was that it was kind of itchy, but besides those, it wasn't that painful.
Okay. And I know the one thing that's really common for people to ask is about their hair. So did you have to have your hair cut? Did you get a head shave?
I did not have to shave my head, as you can see. I had to cut it, but that was because there was a giant knot in it. But they did shave like little parts where the leads were, and that was it. They were pretty good with that.
Great, great. And Johnny is actually in a little bit of an unusual circumstance in that her seizures have calmed down quite a bit following her stereo EEG. And so I think they were having some discussions as to whether she actually might ultimately have a laser ablation, which still might be this in the future, but at least for right now, those conversations have kind of been put on hold a little bit. So Johnny, I guess based on your experience and everything you've kind of gone through, is there anything that you would say to anybody who's considering potential epilepsy surgery, but they're nervous about it, or they don't know if they want to proceed with it? Based on your experience so far, what would you tell them?
I mean, I knew for sure that I was a little bit nervous about just everything. Um, I would say just like think of it as you're in someone else's head or some. I don't know where my wording thing. Like just think of the long-term effects and like how it might change in the long term. That's what I've been doing. And like if you're going to go into like an EEG or stereo EEG, make sure you bring someone who you can stand for that long.
Well, great, great. Yeah, because certainly it's unpredictable how long you'll be in the hospital. That's absolutely right. That's absolutely right. And I think that, obviously, I think that it's one of the important conversations, as we kind of talked about previously, is kind of goals in mind. So, Johnny, clearly you have a goal that you want to drive at some point, and that oftentimes is a major motivating factor for lots of people who are going to have surgery. So keeping that in mind in terms of really, making sure that this is the best option for you, and our goals are going to be met with that before we decide on a procedure, obviously is very important. Dr. Grant, did you have any particular questions for Johnny? If not, we can open it up to the audience.
Yeah, I first want to thank you for joining us. I mean, it's just so amazing you took the time to do this, and you're not that far out from your surgery. You look great, and I really appreciate you, because everyone else is really wanting to hear from people like you, that have been through this and very scared. And like I'm sure you were going through brain surgery. It's not something you want to do all the time, but I guess, thinking through it, like, making that decision to say, okay, I'm going to go ahead to do it. Is that more your decision? Is that your family? Where does that come from that you said, okay, we're going to do this?
It was a bit of both my and my family's. Like my mom made sure I knew like everything that was gonna happen and like what was I'm forgetting the words. Like what would the effects be and what would the pros and cons be to all of this?
The risks of all. Yeah.
So it was my mom was helping me understand, but like I did want to do it because I knew that there were a lot more pros than cons.
Yeah. No, it's hard to think about that, because people sometimes think the stereo EEG is going to solve the seizures, and that's really the first step. That's our homework to figure out then what to do. But like you, it's not uncommon that sometimes the seizures shut down, after this, and they really slow down a lot. And that gives us hope too, that we somehow disrupted that network, right? We put these electrodes in places where the seizure areas clearly didn't like that and started shutting down. And that happens even in the hospital where, you're trying to get a seizure. This is the only time you want a seizure, right?
Mm-hmm.
You have these electrodes in and you don't want to stay in there any longer than you need to. And you had to wait 11 days. You were amazingly patient, for that. So.
Mm-hmm.
I started my first day of junior year was during that.
Mm-hmm.
Oh, great. Do you remember when we stimulated the brain in the hospital where we try to see if your things are moving? Do you remember? Can you describe to people about that?
You mean when they came in and like made the electrodes move?
Yes, to make your like your arm tingle or things like that.
I mean, it was pretty cool. I mean, I don't know how to word things. But they just came in and they like made me read something, and then they like while they stimulated some of the leads or electrodes, and I'm sorry, I just came
Yeah,
back.
no, that's great. Yeah, I'm just trying to get at people to understand because a lot of people think we do that in the operating room, and that we do, in the patient's room where we stimulate kind of remotely and we kind of see how it changes things you're doing that you do every day, like move your hand and talking and reading. But that's super important for us to understand that brain mapping that we're talking about. So, no, you said it great. Great job. So, Bill, yeah, why don't you open it up to see if there's
Yeah.
any.
Great. Yeah. So I think, are we able to either put messages in the chat box? You can drop questions in there. I'm uncertain whether you guys are actually able to open your mics up. If they are, that would be fine as well. But certainly if you wanted to drop questions into the chat, that would be more than welcome. And I'll take a look at that and see if there's anything in there.
There's one question in there, Bill, I can
Okay.
read to you unless you can see it.
Let's see. If my 4-year-old seizures are controlled with medication, would I be unreasonable to want to look into a surgical option? And so typically, if we are able to keep your seizures under control with medication, then we usually go with that option first. And so certainly though, if there are other things that kind of come into play there, and a lot of times that may include medication side effects. So if you are having difficulties being on a medication and having a lot of medication side effects, that would usually drive us to try to switch your therapies to see if we can find one that's more tolerable, because oftentimes that is indeed the case. So usually we would not do an operation on someone who is well controlled on the medications. Let's see. Any other questions? So while we're just waiting, so Dr. Grant, maybe you could elaborate a little bit on some of that Johnny had mentioned. She had talked about a little bit of pain with the S-stereo EEG electrode, kind of back on the back portion of the head. And so could you comment a little bit more on pain with SEEG?
Yeah, we studied this quite a bit in some papers we published because we really wanted to see what the experience was like, for young adults and kids going through this compared to the old days with these grids. And it's a dramatic difference. I mean, the number of narcotics used and all that is much lower. But what's hard for us to control is just what Johnny described, is where some of the electrodes near the muscle, in front of the ear, if you go through that, which we have to sometimes to get to the temporal area, it hurts because when you chew, that muscle moves. You can hold your own muscle and clench your teeth, and you'll feel that muscle tighten up in front of your ear. That's called the temporalis muscle. And we numb that up quite a bit at surgery, but unfortunately afterward, the local anesthetic will wear off. And, if you're trying to chew and eat, it'll hurt where those electrodes are. And that's probably the only area for the first few days it can really be annoying there near the ear. But usually it settles down, and then we take them out. I personally like to take them out in the operating room because then we spend a lot of time with the hair. And we work hard, we shampoo the hair, and it's all knotted, as you know, because it's all wrapped up in this wrap. And I'm sorry you had to cut your hair when you got home. But it's important. And we used to shave more than we do now. And luckily now we don't have to do that anymore. We find safe ways to put these small electrodes in. And with young ladies with a lot of hair, it's a lot more work sometimes, right? So,
Johnny, can you maybe talk a little bit about your recovery from the SEEG? How long did it take you to feel like you were back to your usual self, and did you recover pretty quick? And you're on mute there.
Yeah. It didn't take me a really long time. I think the biggest thing that took me to recover was mainly just getting used to not having the cone cap on my head. And then I could actually like touch my head.
Yeah.
It was just like a weird, like, oh wait, I can do this again. I can do like normal things again that I couldn't do in the hospital. Like I'm not attached to wires and all those things. It was mostly just like me realizing, oh yes, I can turn my camera on for class again. I can just do these simple things.
Right. And then Dr. Grant, so it sounds like, depending on how things go for Johnny, she may ultimately end up having a laser ablation if seizures return. And so what would you comment on in terms of kind of a recovery time for something like that versus a bigger open resection in returns of recovery following a surgical procedure like this?
Yeah, it's a great question. We're always balancing that risk benefit. That's what we need to do with every patient because we want to get seizure free, which means you need to take more. But with a laser, you can't take so much, right? So you have to think, okay, are there hot areas that if you take that out, you're going to be okay? And particularly if you're very close to motor areas, you don't have that luxury to do a big open resection because you'll hurt the motor function and that may not recover. So the laser is very much like the stereo EEG, where we would target one or two or three of those trajectories we already had, like I showed you in that video, and they often go home the next day or a day after. It's a very quick recovery compared to the open surgery. There's a lot more swelling, larger incision. You're in the hospital for a good 3 or 4 days. The laser is a much faster recovery. So we're always thinking, is that a possibility? And it's preferred if it's a deeper area because we don't want to have to do big open surgery and then dive into those deep spots because you're going to make damage along the way, right? So you want as minimally invasive as you can to get there. But all the patient sees is a tiny little stitch where we went in for the laser. So it's quite different in terms of the approach. And it's just so nice to have more options now. Even 10 years ago, we didn't have these options. We didn't have stereo EEG. We didn't have the robotics. We didn't have the laser. We didn't have the deep brain stimulator. We didn't have the responsive neurostimulation. So it's really become an innovative decade for epilepsy, where I would say the 20 years before, not much has changed. So I think it's very exciting for patients and families that at least we can think about options. But you do need a team to think about what's the right thing. You don't want to be wed to one thing, because it may not be the right thing in the end.
So we got another question for Johnny here. So they would like to know that whenever you were in the hospital for that time period, were you bedbound or were you able to get up and move around your hospital room for those 11 days with the FTEG in?
So I was in bed for most of the time, but I had a like cord with all the wires and it was connected to like this big machine thing. I don't know what it's called. But so I was able to move, but it was a bit difficult. My mom had to help me move, like to go to the bathroom or to like go sit in the chair or something. But I was mostly like stuck in bed.
So how did you pass all that time? 11 days in the hospital is a long time. How did you pass all that time there and keep yourself busy?
We did many things. We brought a lot of like puzzles and activities. My mom ended up doing most of them, but we also